Here's what we'll be talking about today. Primarily a focus on LTBI treatment for people living with HIV, but that'll cross over a little bit with some TB treatment as well. Here are my disclosures. And I think it is no secret to anyone on this call that the guidelines, I missed a slide. Okay, this is the key intro that we want to start with, that I'm sure, as everyone here knows, that TB is the leading cause of death for people living with HIV worldwide. And there's excellent evidence that treating latent TB infection in people living with HIV reduces TB incidence and TB mortality. And in addition to the benefits of ART alone that people with HIV experience, adding TB preventive therapy improves mortality outcomes, even in addition to the benefit of ART alone, as has been shown in a number of clinical trials and in a systematic review led by my colleague, Jennifer Ross. We've also seen a lot of new studies of TB, latent TB and TB treatments for people living with HIV. And in the last few years, there have been a number of changes in guidelines and recommendations for the screening and treatment of LTBI, both with people who are living with HIV and people who do not have HIV. So the LTBI guidelines from the WHO were updated in 2018. And the screening guideline at that time was to recommend screening all people with HIV for active TB, and in high TB burden settings to treat presumptively for LTBI if active TB is excluded. So no requirement to screen for LTBI with a PPD or a quantiferon. If you're in a high TB burden setting, the presumption is that the risk of either prior exposure or ongoing exposure is high enough that there is a benefit to just treating with LTBI treatment. And the regimens recommended in this output were 9 months of isoniazid, 6 months of isoniazid, or 3 months of isoniazid and rifapentine. Sorry, I'm having a little bit of a Zoom issue, but that I think we can fix. So in 2020, the CDC issued their updated guidelines for treatment of LTBI. And there were some major priority switches in the regimens being recommended for use. The major recommendation change is that overall rifamycin-containing regimens, which I've helpfully indicated in orange, have been preferentially recommended for treatment of LTBI. And the recommended regimens are 3 months of daily isoniazid and rifampin, or 3-HP, 3 months of weekly isoniazid and rifapentine, or 4 months of daily rifampin. And these are now preferred over the isoniazid containing regimens of either 9 months or 6 months, with the other change in guidelines identifying that the isoniazid only regimens do have, as their longer duration, increased risk of hepatotoxicity in the longer course. So with the INH only mechanism regimen, the 6-month treatment is recommended preferentially over the 9-month now, and that's new. So overall, the motivation for these changes are to prioritize the shorter course, which are the rifamycin-containing regimen, because people have better adherence and there's overall better completion of shorter regimens. So either the 12-week or the 3-month daily or the 4-month daily medication regimen. The downside of the shorter course regimens, including rifamycins, is that the rifamycins do have some pretty significant drug-drug interactions with many common medications. And so their use can be limited by these drug-drug interactions. In addition to antiretrovirals, which will be primarily what we're going to talk about today, interactions with warfarin, hormonal contraceptives, anti-epileptic drugs, glucocorticoids, and opioids are kind of the major classes of meds that present barriers to many of our patients for taking the rifamycin regimens. And some of those overlap with classes of medications also frequently taken by people living with HIV, in addition to antiretrovirals. So although the INH only regimens are longer and potentially more toxic in the longer form, they do avoid this issue of rifamycin interactions, and that we will see becomes significant with people living with HIV on antiretrovirals. So the DHHS guidelines for treatment and prevention of opportunistic infections in people living with HIV have been recently updated. And so this is a small text snapshot from the guidelines, which I have hopefully helpfully summarized in large text, that the preferred regimen recommended in this guideline is for people living with HIV is 9 months of daily isoniazid with 3-HP as a acceptable alternate regimen for people who can take that and for people whose antiretroviral regimen allows that. So this is the guideline statement. There has been an update review by the panel to also state that 6 months of daily isoniazid is also allowable, as well as 1 month of daily isoniazid and rifapentine, the ultra short course TB prevention regimen. These recommendations have not yet made it into the guidelines, but they are the official recommendations of the panel. And so if you go on the website for the DHHS guidelines, you will be able to see the panel recommendations as well, which have also been summarized and highlighted here. So the guidelines also specify for a US-based population that all people living with HIV should be screened both for active TB and for latent TB. So we recommend screening at baseline and entry into care with either a PPD or an interferon gamma release assay. And for those people who have a positive latent TB test to treat latent TB in these individuals. And the selection of regimen needs to take into account a variety of things, the most important being the patient's antiretroviral regimen and potential, but also patient preference, thoughts about access to support for adherence, and what kind of pill burden the patient's going to experience with either the ARV or the TB, the LTBI regimen. And I'm going to go into some detail about the different conflicts with different antiretroviral regimens and different LTBI treatment regimens. But there are a few ways to simplify thinking about it. The main takeaway, which I'll start with and then emphasize throughout, is that efavirenz containing regimens can be used with almost any, well, really with all latent TB treatment regimens. Dolutegravir, which is an integrase inhibitor and which forms the backbone of most first-line antiretroviral treatment, that class of medication, can be used also with all latent TB treatment regimens, although it may need to be dose adjusted for some of them. So again, the guidelines are allowing 6 or 9 months of daily isoniazid, and that's a free pass for any antiretroviral regimen, no adjustments necessary. For others, for 3-HP, efavirenz and dolutegravir can be used, and then with the and we'll talk a little bit about specifics. And then the once daily isoniazid rifapentine for 1 month. This is the ultra short course. That one, currently there's only evidence to recommend that with efavirenz containing regimens, usually a tripla, and that can be used without any dose adjustments. So it's still a little bit TBD to be decided if we can use this regimen with, in particular, dolutegravir or other integrase inhibitor containing antiretroviral regimens. The studies weren't done in those populations. So when thinking about making the choice for what LTBI regimen or TB treatment regimen, really mostly LTBI regimen. Mainly the issue is that the rifampin and rifapentine are potent inducers of cytochrome P450, which causes interactions with many antiretrovirals. And so trying to decide whether switching the ART is going to be a priority or choosing choosing the LTBI regimen is an ongoing shared decision-making discussion to be had with patients to determine sort of what are the priorities of treatment, what are the limitations to adherence, and to figure out which is the best to adjust. So I sort of frame the choice of TB preventive therapy and ART as sort of like blood types, universal donors, universal receivers. So universal TB preventive therapy is INH. It's compatible with all ART. There's no need to change an antiretroviral regimen. So if it's going to work out for that patient who's on antiretroviral therapy, the default go-to is always going to be INH if they can take INH for whatever other reason. In contrast, the universal ART regimen that is compatible with all LTBI treatments without needing dose adjustment is Atripla. So that's efavirenz, tenofovir DF, TDF, and emtricitabine FTC. And it's a single pill, once daily regimen that used to be common, used to be a first-line treatment in this country and around the world, but now is no longer. And that's not because it's not a good combination ART, it still is highly effective, but it is not as potent as dolutegravir and integrase containing regimens. So those have largely dominated the first-line recommendations for therapy, but just because you're not seeing a lot of people on Atripla anymore doesn't mean it's not a good drug. And so that, please keep it in mind as a fallback ART regimen that is highly effective and can be safely used without interactions with all LTBI and TB treatments. Pretty much all other LTBI and ART combinations are going to require some adjustment in order to co-administer. So let's go into a little bit of detail about that. And I'm sorry, I'm just seeing now that some things are popping up in the chat, and I just want to take a look at what these are saying. Okay, so thank you, Sylvia, for letting us know about the treatment guidelines. So I think that will be updated soon. And so we have a question about what makes adult HIV providers use 9 versus 6 months. So the issue is that the evidence is best for 9 months, and best in terms of outcomes of the incidence of active TB. It's a lower risk of active TB in people who get 9 months of treatment versus 6 months. That said, those additional months get you kind of incremental benefit in reduction of TB risk with a pretty significant downside of both a longer course of meds for people to take. And we know people have trouble taking an extra daily medication for any amount of time, and that 3 months is pretty significant. And so it is an issue with adherence. And then there's also the issue of increased hepatotoxicity, which is being increasingly realized. And so that's the reason why in the most recent LTBI guidelines, the six months of daily INH is preferred over 9 months of daily INH. In most of the world where daily INH is used as preferred TB preventive therapy, it's the 6 months. So the WHO guidelines for TB preventive therapy is generally 6 months. Many national programs have 6 months. And even here, we consider someone who have completed LTBI treatment if they've completed 6 months of INH within a 9-month time period. So there is old good data that you get some incremental benefit with the extra 3 months to 9 months. But I think increasingly we're moving towards 6 months to optimize the adherence, hepatotoxicity, and completion benefit. And then we have a question, does rifabutin have a role in the treatment of LTBI in people living with HIV? That's a really good question. It is not part of any of the recommendations or guidelines. There are probably some cases where if there's a necessary use of rifabutin in the case of interactions with antiretrovirals, there may be a few cases where a substitution is preferable, or if there's a significant risk of hepatotoxicity with a rifamycin that is compatible. But I personally haven't used rifabutin for LTBI treatment and would probably think about it only after having encountered issues with either hepatotoxicity or other like failure. So it's not guideline driven treatment at currently. And I certainly welcome other folks to chime in on that with their experience as well. Before I get back into the alphabet soup of antiretrovirals, did I hear somebody else coming off a mic with another question? I'm happy to have this be a little bit more of a discussion.
No, that was a whoopsie doodle.
Okay, all right, no problem. All right, so great. So this is the slide that is meant to kind of highlight both some of the most common antiretroviral elements seen and highlight the does not play well with rifamycins and is definitely going to be not allowable, and the few green lights of drugs that are compatible with rifamycin, so you can be using those. So in the INSTI category of antiretroviral, these are the integrase inhibitors. These are incredibly potent, and most antiretroviral regimens that are being initiated in people living with HIV now are integrase inhibitor containing because they work so well. Unfortunately, bictegravir, which is one of the first line recommended INSTIs, which is provided as a treatment and as part of Biktarvy, that is not compatible with rifamycins. Rifampin lowers the concentration of bictegravir below the therapeutic threshold, and so even with dose adjustment, can't be given it. You can't get therapeutic levels of Biktarvy in people taking rifampin or rifapentine. So that's a no-go. If someone is taking Biktarvy and they need LTBI treatment or TB treatment with a rifamycin, then that is going to need to be switched. Dolutegravir, same class of antiretroviral, an integrase inhibitor, and that is okay to be given with RIF and with rifapentine. So dolutegravir is fine to be given unchanged if rifapentine is given weekly. Sorry, this is I want to make sure that what is on the slide is clear. Dolutegravir is okay with weekly dosing. If RIF or rifapentine is given daily, such as in the 1-HP or in TB treatment with daily RIF or a 4 months of daily RIF, then dolutegravir dosing needs to be increased. Instead of being given 50 milligrams once a day, it needs to be given 50 milligrams twice a day in order to maintain therapeutic concentrations. And that dose increase should persist for 2 weeks beyond the end of the rifamycin being given, so that there's enough time to clear and reset the P450 once RIF is off. So dolutegravir remains a very good antiretroviral treatment option for people who need a potent antiretroviral regimen, but need TB or LTBI treatment. Raltegravir, also in this class, much less commonly used, and it, like dolutegravir, it's okay to be given with no dose change no dose adjustments with weekly rifapentine. But there have been studies shown that it should not be given along with a daily rifampicin, so not daily rifampicin LTBI or TB treatment. It's inferior to efavirenz and should switch that regimen to an efavirenz containing regimen. Many of the current first line single pill regimens for ART contain a booster. Cobicistat is a commonly used booster, and that's a hard stop with rifampin. So none of the cobicistat containing regimens can be given with either of the rifamycins, rifapentine or rifampicin. Of the NNRTI, so most of the ART regimens are given with a combination of an integrase inhibitor and 2 NRTIs. And tenofovir, which comes in 2 forms, is an anchor of those regimens. The 2 forms of tenofovir are TAF and TDF. So TDF is part of Truvada, and along with emtricitabine, TAF along with emtricitabine is Descovy. And here's where the fundamentals of the drug are good. So tenofovir, very effective, useful in an ART combination, but in the TAF formulation, doesn't play well with RIF. So there are PK concerns about distribution and therapeutic levels. So TDF is okay and not TAF is kind of the rule going forward. I'm only going to speak briefly about protease inhibitors. This is a class of antiretroviral that are generally pretty infrequently used. The newer protease inhibitors and all protease inhibitors are boosted mostly with ritonavir, some with cobicistat. And the good rule of thumb is that don't use protease inhibitors with RIF. If you absolutely need to use one, the one that can be used is lopinavir boosted with ritonavir, and that can be given with TB treatment, but it requires a doubling of the dose of lopinavir ritonavir, and again continued for the 2-week tail after the RIF is finished. And boosting that comes with, or doubling that dose comes with a lot of side effects. It's really not preferred, so we try to stay away from the PIs. Moving back to the chat, I see that there's a question about regarding the duration of isoniazid-only treatment. What's the magnitude of increased effectiveness of 9 months versus 6 months, and versus the magnitude of the increased risk of hepatotoxicity? So great question. The best data that we have for this, to answer this question, is unfortunately pretty old and not in people living with HIV. So the 9 months versus 6 months data comes from George Comstock studies that were done in Bethel, Alaska in the 60s, maybe 70s. And they showed that the benefit of 9 months is basically a 99% reduction in TB incidence in the 5 years following the end of, in the follow-up period that was followed in that population, whereas 6 months was a 75% reduction in the incidence of TB compared to no TB preventive therapy. So it's a reasonable benefit, but again, at a time where and a time in a population where there was generally a lot more TB than what we see in our communities in the US, and there was not none of those individuals had HIV or were being treated with antiretrovirals. So a little harder to get a read on what the benefit we would expect to see now. And the magnitude of the increase in risk in hepatotoxicity, I will have to get back to you with numbers on that. I can't unfortunately give you a great number off the front of my knowledge. All right, I'm going to warn folks that there's going to be a lot of letters and abbreviations as we get into a little bit more discussion about ART. If it looks too scary, just always go back to the universal TB treatment and universal ART regimen are the things that you can rest your hat on. But just to cover a little bit the scope of what you can expect to see your patients on coming to you on ART if you're thinking about TB treatment. I want to at least go over a little bit about what's kind of out there. So these are the first line recommended. Sorry, I think I have a trigger finger that makes me go 2 slides ahead. These are the first line ART regimens recommended for initiating people with HIV on ART treatment in the US. And so, like we talked about, the first line ART regimens should be an integrase inhibitor, high potency antiretroviral with 2 nucleotide reverse transcriptase inhibitors. And so we talked about Biktarvy. That's a single pill, combination pill that has all of these 3 drugs in it. And I've colored that red because this is a no-go with rifampin for LTBI or TB treatment because of both the Biktarvy and because of the TAF, the tenofovir AF variant used here. Triamec is a dolutegravir containing combo therapy, not very commonly used, but is in the first line regimen. You may see that. And then between Biktarvy and probably the second most common starting regimen people often get put on is dolutegravir plus one of the tenofovirs and either FTC or 3TC. So that can come as a combination of dolutegravir plus Truvada or dolutegravir plus Descovy. And Descovy is the tenofovir combo that has the tenofovir AF, and that's a no-go for TB treatment or rifamycin. There is a recommendation. Some people are getting started on a 2-drug combination of dolutegravir plus 3TC. Not super common, but you may see that as people coming in with their starting regimen. If people have a relatively low viral load to start, that's okay, and are not at risk of HBV. Other initial regimens people are started on, there's another combination, single pill combination. Genvoya is the version with TAF, and its companion drug, Stribild, is the combination that has TDF. This has an integrase inhibitor, but it's boosted with this little C is for cobicistat booster. So this is an integrase inhibitor boosted with cobicistat and combined in Genvoya or Stribild. Again, this is one because of the boosting and because of the TAF is not a med that can be given with TB treatment or rifapentine for TB prevention. Boosted PIs they're listed here as alternate initial regimens if needed, if people are very treatment experienced, if they have resistance to other medications, but relatively unusual to see somebody started on a protease inhibitor regimen, and we're not going to spend a lot of time talking about them. They don't play terribly nicely with TB treatment or prevention, other than isoniazid. And then although I'd mentioned it's no longer in the first line regimen, it is an acceptable alternate initial regimen. This is the ATRIPLA, the efavirenz plus tenofovir plus FTC regimen, which should be given when you're thinking about TB treatment in the ATRIPLA combination format, which is 1 pill once a day, or if they need to be given separately for whatever reason, efavirenz should be given at the 600 milligram dose and not the sometimes given reduced dose efavirenz, which is probably as effective, but there may be a small effective rifampin that lowers the efavirenz concentration. So we should stay away from that. And then just the last kind of red flag drug, Odefsey and Complera. It's another single pill combo of multiple medications that contains rilpivirine and TAF or TF. So definitely the TAF is out, and in general, the rilpivirine is not a medication that plays nicely with our RIF. So a lot of drugs you might see, and basically, unless what you're seeing is a tripla in a patient coming in, Anything else they might be on is probably going to need an adjustment, certainly for TB treatment, and maybe for a non-isoniazid LTBI treatment. So this is the reference table I've made for myself to really just simplify what ART can be used for the different TPT regimens. So for the daily 3-HR, any of the rifamycin containing regimens, your options, the simplest options are tenofovir plus dolutegravir, where you have to remember to double the daily administration of dolutegravir, or Atripla, which is this bottom combination of efavirenz containing with Atripla. With 3HP, the nice thing about 3HP, the weekly isoniazid and rifapentine, is that you don't need to change the dose of dolutegravir. So it's still 1 pill once a day of dolutegravir, no dose adjustments necessary. For R, you can use dolutegravir again, but the dose needs to be doubled, or efavirenz. And then neither of the isoniazid regimens require any change to ART. I want to speak briefly about the 1 month daily isoniazid and rifapentine. This is a 1 month daily TB prevention regimen that was shown to be non-inferior to 9 months of isoniazid in a large global trial. And many people in the study had HIV. They were all taking efavirenz-based ART. So this is really good data for people who are on Atripla or could be switched to Atripla. There is no data on this regimen, this daily isoniazid and rifapentine, in people taking integrase inhibitors, which is the majority of people in the US. So still TBD about who, if integrase inhibitors can be used with this single month regimen, but it's an exciting potential for having an ultra short course of LTBI treatment for patients, and can be given with Atripla. So that always is an option. So just to kind of hammer down the considerations of when should you be thinking about switching ART, when should you be thinking about choosing an easy LTBI regimen. We know that switching someone's ART is a really vulnerable time for increasing the risk of loss of virologic suppression. So anytime you think about switching somebody's ART from a regimen that they're established on, they have virologic suppression, there is an inherent risk that that interruption in treatment could put them at risk for losing viral suppression. And so minimizing the complexity of the switch to minimize that risk of losing suppression is really important. So thinking about, is your patient going to be supported in making a switch? Are they going to be able to maintain good adherence? How complicated is the switch? If you're just switching, let's say somebody is taking dolutegravir and Descovy, which is TAF-FTC. If you switch that regimen to dolutegravir plus TDF-FTC, Truvada, it's a pretty invisible switch. It's the same number of pills the person's going to take, the same fundamental medication, same side effect profile. So that's probably not too complicated a switch to make. But once you start switching from 1 pill daily, if someone's on Biktarvy, for example, a single pill regimen, to then 2 pills, but one of them's twice a day, that gets a little more complicated, and depending on the patient, that may not be optimal for them. And the 2-week tail also can be hard to understand, and may take a little work explaining to patients that they have to keep taking a double dose of dolutegravir for 2 weeks after they finish the TB treatment or the LTBI treatment. And the reason for that is because if they don't double the dose of dolutegravir, the risk is that the ART stops working and lose viral suppression, and the worst case scenario would be developing resistance as well. If patients are highly treatment experienced, meaning they've been through many different kinds of ART throughout their HIV treatment, they may not have very many options for ART that's available to them. So they may have accumulated a lot of different kinds of resistance. They may be on a regimen that may be the only ART regimen that works for them. So in the case of picking an LTBI regimen, the ART regimen may really have priority, and it may not be possible to switch that to something friendlier or something that plays nicely with 3HP. So that may restrict your LTBI options to isoniazid. If they need TB treatment for active TB, they need TB treatment, and so then it becomes a little bit more of a complicated exercise, and that's one where I think anyone would recommend consulting with. I mean, I would consult a colleague to make sure that I was picking a regimen for folks who are really treatment experienced. It's not straightforward. And then the last, but certainly not least, is understanding the patient's priorities. Some people are really attached to their antiretroviral regimen. It works really well for them. It's kept them suppressed for years. They don't want to change for any reason. And if that can be accommodated, that's going to have a big effect on someone's adherence and success with both treatments. And some people say, okay, well, I will take some medication for this latent TB that you say I have, but I don't believe it. I'm only going to do it for 3 months and then we're done. So if a short LTBI regimen is a priority for that person, then maybe a switch to an ART, temporary switch to an ART regimen to enable a short LTBI regimen could be a priority for that patient.